Hello, welcome to Dr. Amaye Sports. It is always lovely to have you here. Today we'll be discussing the sepsis spectrum. We'll begin our discussion from by looking at SIRS, Systemic Inflammatory Response Syndrome, and then we'll progress to discuss sepsis, and then we'll look at severe sepsis and septic shock, and eventually we'll finish by discussing multiple organ dysfunction syndrome. SIRS stands for Systemic Inflammatory Response Syndrome. It is a syndrome characterized by an exaggerated response of the body's immune system to a noxious stressor. Now, this essentially what happens is that there's an imbalance between pro-inflammatory and anti-inflammatory mechanisms, with the body tilting towards pro-inflammatory mechanisms, such that inflammation becomes widespread to systemic limits. SIRS can be caused by quite a number of factors, ranging from trauma to surgery to infectious agents, ischemia, reperfusion injury, malignancies, as the case may be. I would quickly mention here that when SIRS is caused by infections, what we have is sepsis. We will discuss more about this shortly. All right, now you would note that these agents or these stressors that have been itemized are either either endogenous or exogenous, that is, they can arise from within the body or outside the body. For example, trauma is a stressor arising or originating outside the body, however, while malignancies are stressors originating from inside the body. The whole aim of this inflammatory response is attempts of the body to localize the inflammation and to prevent it from getting to systemic limits. Okay, to make a clinical diagnosis of SIRS, there are certain criteria that must be met. Now, there are four of these criteria. At least any two of these four should be present to make a diagnosis of SIRS. Now, one is that of temperature. For a diagnosis of SIRS to be entertained by the clinician, the patient's body temperature should be above 38 degrees Celsius or less than 32 degrees Celsius. One cause of elevated temperature in these patients is the elaboration of cytokines. Now, cytokines are elaborated into the blood and they migrate to the temperature set point at the hypothalamus. There, they increase the core temperature of the body. Another criteria to look at is the heart rate. Now, for SIRS to be considered, the heart rate should be above 90 beats per minute. Now, there are quite a number of factors that can cause this increase in heart rate. One is that in SIRS, there's an elaboration of stress hormones, the elaboration of catecholamines. Now, these can impact the heart by increasing the rate, the frequency of cardiac activity, or by increasing the heart rate. Again, with increasing temperature, the heart rate would also rise. Remember that per degree rise in temperature, the heart rate increases by about 10 beats per minute. Another criterion to look at is the respiratory rate. So as the heart rate increases, also the respiratory rate is another criteria to look at when diagnosing SIRS. Respiratory rate should be above 20 cycles per minute, or the partial pressure of carbon dioxide should be below 32 millimeters of mercury. Now, especially when SIRS is caused by an infectious agent, there is a background metabolic acidosis. So the body begins to look for compensatory mechanisms to ensure that this acidosis is corrected. Now, one of those compensations is seen at the level of the respiratory system, where the body increases the rate of respiration so that as much carbon dioxide is dissipated as possible, such that the partial pressure of carbon dioxide begins to drop. And with that, we have some sort of respiratory alkalosis. Now, this is the body's attempts to try to correct the metabolic acidosis to try to establish homeostasis. Now, the first criteria to look at to consider when making a diagnosis of SIRS is the total white cell count. Now, the total white cell count should be above 12,000 cells per microliter or less than 4,000 cells per microliter, or there should be more than 10% of burn cells in the peripheral blood film. So again, to make a diagnosis of SIRS, at least two of these criteria should be met. Now, the causes of SIRS are quite broad and they're highly non-specific. All right. Again, yeah, this image just again here this image emphasizes that when there is an infectious cause going on with SIRS, what we have is sepsis. At least we should put that at the back of our mind. When SIRS is caused by an infectious agent, all right, that gives rise to sepsis. All right, we'll discuss more about this subsequently. Okay, now here are a couple of non-infectious agents that can give rise to SIRS: pancreatitis, trauma, burns, among many others. Now, all of these can give rise to SIRS. However, for emphasis again, when SIRS is caused by an infectious agent, as we see in this side of this image, it could be bacteria. This infectious agent can be bacteria, can be caused by fungal agents or parasitic agents or viral agents, among many others. So we have sepsis, and sepsis can progress to severe sepsis and septic shock. And if no intervention is made at this point, this can progress to death. Okay, and we could also see again here this also represents the spectrum we highlighted in the previous slide. On the previous slide, where we have SIRS, and then from SIRS to sepsis to severe sepsis to septic shock and then to death. Remember again that when SIRS is caused by an infectious agent, that would give rise to sepsis. So, how common is SIRS? In one American study that enrolled over 269,000 patients, it was found that SIRS is that as much as 46.6% of these patients met the criteria for SIRS. In another study conducted in Asia, around 200 patients were enrolled, and as much as 78% of patients of these patients met the criteria for SIRS. And about the researchers noted about 19.5% mortality. In a local study conducted in Tanzania by Nariadara et al., this study used the sample for this study was composed of a pediatric population, and it was found that 39.9% of participants in this study met the criteria for modified SIRS. Now, modified SIRS is in pediatric population. What is discussed is modified SIRS. Now, for the pediatric population, remember that earlier we highlighted four criteria for SIRS. We talked about the temperature, we talked about the heart rate, we talked about respiratory rates, and we talked about the total white cell count. So for pediatric population, there must be a normality in temperature. This can be elevated temperature or reduced temperature, and then there must also be white cell count, an abnormality in white cell count. This can be reduced or elevated. So one of these must be present. This here or this. One of these must be present together with any of these to meet up the criteria for SIRS in pediatric population. That's because if you remember, children heart rates and respiratory rates are naturally higher as compared to adult population. So if we just rely on these two, then all pediatric, all and then children will be considered to all have SIRS. So because of this, it was made mandatory that the temperature abnormality or white cell count abnormality must be present to make a diagnosis of SIRS. We'll now look at this. We'll now pay more attention to the pathophysiology of SIRS. Now, this was very well described by Roger Bone, and he did this in 5 continuous stages. Take a closer look at the pathophysiological mechanisms of SIRS. Okay. Now, let's have a hypothetical blood vessel. Right, we have something like this, this beautiful blood vessel going into, to supply blood to end organs, and then we have something like this here to represent the endothelial cells of these blood vessels. All right, remember that blood vessels are lined by endothelium. Yeah, so let's this represent the endothelial cells. And we have here tissue. Okay, this is tissue supplied by this hypothetical blood vessel. Now we mentioned that in cells there is exaggerated immune response to an insult. So let's imagine that we have some form of insult here. Now this insult can be in the form of an injury to the body. Let's say this is a patient. Let's call this Mr. A that just had a road traffic accident. Now, consequent to this road traffic accident is this injury that this person has here. Alright, so this injury here is going to trigger local inflammation. So what happens is that there are immune effector cells within this region will be activated and subsequently would elaborate cytokines. Cytokines elaborated by these immune effector cells are interleukin 1 and tumor necrosis factor alpha. Now, these cytokines activate the reticular endothelial system, and this activates a whole lot of local inflammatory activities. Now, the whole idea of this is aimed at establishing wound healing, okay, wound healing, and to also arrest inflammation here, such that inflammation does not spread to systemic limits. So one of the first things that happen is that there is release of nitric oxide and also prostacyclins. So what nitric oxide and prostacyclins do is that they bring about local vasodilation. So okay, so they bring about local vasodilation. So that the blood vessel that we saw earlier begins to dilate. All right, dilate simply means begins to get wider. All right, and the tight junction between the endothelial cells become compromised. And this gives rise to leakage channels in between that occur in between the endothelial cells. So all of these now here are leakage channels, all right? And remember, we still have okay. Remember, we still have the local tissue here, and this is the insult here that we do, right? So now, these leakage channels, remember what is here, we have plasma, blood cells, and all of these here, all right? So because of these compromising the tight junction of the endothelial cells, the cells lining the vascular endothelium, so protein-rich plasma will begin to leak out into the interstitium, all right? And then so fluid here, protein-rich plasma will leak into the interstitium, and also there will be margination. Now, that's white blood cells will begin to tend towards the walls of the blood vessels and will also pass through to the interstitium. Now, this fluid that leaks goes with it and heat. Remember that heat is distributed in the body by blood. Now, blood is made up of plasma and blood cells. So this is plasma, alright, and blood cells leaving the vascular compartment to the interstitium, and together they go with heat. So one of the features of inflammation is that there will be heat. Alright, so that this area where this fellow got this injury would be the will which demonstrates differential warmth. So this area would feel warm to touch. Now, together with this heat, will be together with this fluid, as this fluid also goes into this interstitium, there will be swelling. All right, because the interstitium will begin to swell to try to accommodate the extra volume of fluid that is going into its space. So there will be heat and then there will be swelling. Okay. Now, again, this is another component of another cardinal sign of inflammation. Now, the cytokines that are elaborated also stimulate the somatosensory fibers, right? There are somatosensory fibers here, somatosensory fibers. Okay, now these are nerve fibers that are distributed around this local area. So the cytokines that are released would stimulate these nerve fibers, and this will give rise to pain, alright, which is also a cardinal feature of inflammation. Now, so the cytokines here stimulate the somatosensory fibers that are distributed here, and this will give rise to pain. This pain will give rise to loss of function. Okay, the individual would not be able to move the affected body part as commonly as easily as he or she used to. Now, the physiological importance of this loss of function is that it gives the body a chance to rest the affected parts to allow for healing. Okay, now the whole idea of all of these is to ensure that this inflammation is arrested at this local level. It does not become widespread. Okay, so remember that we were looking at the pathophysiology of SIRS, and we mentioned that Roger Bone describes SIRS in five distinct stages that are interlinked. Now, what we just talked about here is actually the very first stage, alright, as described by Roger Bones. Now, there is increased activity of pro-inflammatory cytokines, interleukin 1 and 2 necrosis factor, and they are all giving rise to local inflammation, achieving wound healing. In the next stage, as described by Roger Bone, the next stage is interesting. So in stage two of the pathophysiology of cells, the body begins to trigger mechanisms to establish homeostasis. Okay, the body begins to activate anti-inflammatory anti-inflammatory activities that would um, put to check the pro-inflammatory activities that are released by the body. The body does this by releasing growth factors, activating macrophages, and recruiting platelets, and all of these platelets and all of these put together. So in stage two, anti-inflammatory mechanism, comes head to head with pro-inflammatory mechanisms. Now, the whole idea is to ensure that inflammation is checked and it remains limited to the local region where this stimulus or this insult is is found. All right. Now, in its third stage of SIRS, as described by Roger Bone, what happens is that, of course, remember that we define SIRS. We said that SIRS is an exaggerated immunological response to infectious stimulus. So, because the immunological response is exaggerated, there is a very high chance that while the pro-inflammatory forces try to counterbalance anti-inflammatory forces, as we saw in stage two, what will happen here is that it is expected that the pro-inflammatory forces would overwhelm the forces of the anti-inflammatory forces, and this will give rise to continuous inflammation. Okay, so remember in the previous diagram we noted the endothelial cells that line the walls of the blood vessels, and we did mention that during inflammation the tight junctions in between these cells are compromised, and this gives rise to leakage channels through which plasma and white cells pass to the interstitium. Okay, leakage channels through which they pass to the interstitium. All right, and they go together within warmth. They also cause swelling. The somatosensory fibers located here are stimulated to cause pain, and then there's loss of function. And all these four are the classical or the cardinal components of inflammation. Now, so what happens now is that because the pro-inflammatory mechanisms significantly overwhelm the anti-inflammatory mechanism, there is continuous endothelial damage. So endothelial damage is continuous; it goes unchecked. Now this continues even down to the blood vessels supplying end organs like the kidneys, for example. So as a result of this, there will be microvascular coagulopathy, coagulopathy. All right. So what this means is that these small blood vessels that supply end organs, in this instance, we have the kidneys here, or the coagulopathy here, the formation of thrombus within this organ, and this will further compromise. Okay. So imagine this now happening to all other organs of the body, right? Other end organs of the body. So this eventually will give rise to multiple organ destruction, dysfunction syndrome. All right. So this is what happens in stage three of SIRS. All right. Yeah. So this is what happens in stage three of SIRS. So we have highlighted the stages. So I'll just do a quick recap. So in stage one, as noted by Roger Bones, in stage one, all right, there's local inflammation. This is the body making attempts to arrest this insult and to make sure it does not spread to systemic limits. In stage two, because this local inflammation um, becomes exaggerated as it is, of course, as we've already mentioned when we were introducing the concept of systemic inflammatory response syndrome. The body elaborates anti-inflammatory mechanisms to try to put this local inflammation to check. Now, of course, because there is exaggerated inflammatory um, response in SIRS, we expect that the pro-inflammatory cytokines would overwhelm the pro-inflammatory mechanisms will overwhelm the anti-inflammatory mechanisms. So, of course, and this will give rise to continuous endothelial damage. There will be coagulopathy and the eventual compromise of the end organ blood supply. And of course, that gives rise to multiple organ dysfunction syndrome, as we eventually see subsequently. So, as pro-inflammatory forces go, head to head with the anti-inflammatory forces, as we see in cells, with the body trying to establish homeostasis. There's a brief moment in stage 4 where the pro-inflammatory forces would be overwhelmed. Now, this is just a transient moment, a very brief moment. All right. So the cytokines, the immune effector cells, and all of these complexes will be overwhelmed in that brief moment noted in stage 4, as now this is noted by Roger Bone, right? So in this brief moment, because of this suppression, the body becomes immunocompromised. Alright, so there is some form of immunosuppression that goes on with this. So this makes the body to be vulnerable to be exposed to infectious agent. Alright, so in stage 4 of the such pathophysiological mechanisms, there is increased risk of infection. So if infection does come in eventually, if infection comes in eventually, it will give rise to, of course, you already know that, sepsis. Okay. Now, in stage five of SIRS, in stage five, in stage 5 of SIRS, inflammation has gone, inflammation has gone systemic, and there is widespread endothelial damage. There are pro-inflammatory factors, immune effector cells, inflammatory cytokines, tumor necrosis factor, interleukin 1, among many others, are elaborated at high ceiling levels. Also, there is widespread microvascular coagulopathy affecting several end organs. And so this will now give rise to multiple organ dysfunction syndrome. Okay, so far we have been discussing SIRS, and at this point you may have realized that with interleukin 1 and tumor necrosis factor alpha are important important mediators to cells. They are actually play very crucial role. Alright, in cells they are released within the first hour. Okay, they are released and they play important role in tilting the balance towards the pro-inflammatory activities. Remember that we mentioned that there's a struggle between the pro-inflammatory mechanisms and the anti-inflammatory mechanisms, right? And for cells to happen, these pro-inflammatory mechanisms would have to overwhelm the anti-inflammatory mechanism. Now, interleukin 1 and tumor necrosis factor alpha play crucial roles to make this happen. Now, in the next few minutes, we shall be discussing specific roles these mediators of inflammation play. All right, so let us note here interleukin 1 and tumor necrosis factor alpha. Now, they go about executing their functions in cells through three important mechanisms. Um, one of these pathways through which they do this is the propagation of cytokine cytokine pathway. Alright, the propagation of cytokine pathway. So what happens here is that once there is an application of a noxious stimulus like an injury, like a malignancy, like infectious agent, as the case may be. Of course, as we mentioned earlier, within the first hour there is elaboration of interleukin 1 and um, tumor, tumor necrosis factor alpha, right? Okay, there's elaboration of yeah. So interleukin 1 and 2 necrosis factor alpha. Now, on the action here, what they do is they act on nuclear factor kappa B. All right. Now, before now, nuclear factor kappa B remains bound to ACE1 inhibitor. All right, inhibitor. So it remains bound to its inhibitor, in other words, it is inactive. So interleukin 1 and 2 necrosis factor alpha they come in and they attack this bond that keeps nuclear factor kappa B attached to its inhibitor. They dissociate this bond and this liberates nuclear factor kappa B. Now, what the impact of this is that once nuclear factor kappa B is dissociated from its inhibitor, it becomes active and itself dissociates from its inhibitor, it becomes active and it further stimulates the release of other cytokines like interleukin 6, like interleukin 8, like interferon gamma. Okay, interleukin 6, interleukin 8, and interferon gamma. Now, these are other pro-inflammatory cytokines that will go on to activate the stress pathway to ensure that we move from stage 1, where the body is trying to localize the uh, inflammation, ensuring that it does not spread, and then through stage 2, and then up to stage 3 and stage 4, where there's further insults of further uh, inflammatory activities and further endothelial damage, coagulability, coagulopathy, and other mechanisms that we've already cited. Now, we should note here briefly that when SIRS is caused by an infectious agent, there is more the release of tumor necrosis factor alpha is quite high as compared to when SIRS is caused by non-infectious agents. And this tumor necrosis factor alpha plays a very important role in the occurrence of fever because it acts on the temperature set point in the hypothalamus and then increases the core temperature of the body. So this is one mechanism through which this happens. Um, another mechanism to look at, another mechanism through which interleukin 1 and 2 monocytic factor alpha bring about their effect is through the alteration of the coagulation, right? And this leads to several microvascular coagulopathies, right? Microvascular coagulopathies. Okay, yeah. So let's take a closer look at this and let's see what happens again. Again, activation or elaboration of interleukin 1 and tumor necrosis factor alpha. Hmm? Okay, and tumor necrosis factor alpha. Now, what is that there is it activates plasminogen activator inhibitor 1. Okay, plasminogen activator inhibitor 1. Now, this is plasminogen is involved in fibrinolysis. Now, fibrinolysis is the breaking down of blood clots. Alright, so this is the process that occurs within the body that ensures that blood clots don't accumulate in the body and cause further havoc. So, once the inhibitor of this plasminogen is activated, it once the inhibitor plasminogen is activated, it interferes with this fibrinolytic function, and then so fibrinolysis is impaired. Mhm. So fibrinolysis is impaired. Also, what also happens is that the we already talked about the endothelial injury, that the endothelial injury that goes on, right? So as a result of this endothelial injury, there is a release of tissue factor. Okay, this tissue factor will go on to trigger the coagulation cascade. Okay. Yeah, so we have seen two possibilities here that interleukin 1 and small pieces factor alpha would cause about the release of plasminogen activator inhibitor 1, and these will go on to interfere with the fibrinolytic functions of plasminogen. Again, further epithelial injury caused by the activities of interleukin 1 and tumor necrosis factor alpha will bring about the release of tissue factor, and tissue factor again will activate the coagulation cascade. Alright, now so TNF alpha and interleukin 1 also bring about the inhibition of antithrombin. They bring about the inhibition of antithrombin protein C. Now, again, all of these further would worsen the coagulopathy. Okay. Now, we see that all these functions from the plasminogen activator inhibitor 1 release that alters fibrinolysis to endothelial injury, giving rise to tissue factor that also further activates the coagulation cascade to the inhibition of antithrombin and the activated protein C that further worsens the coagulability. All of these would, lead to uh, widespread microvascular microvascular thrombosis. Okay. Further, they will worsen the capillary porosity. Okay. Remember those endothelial, those leakage channels we mentioned when the tight junctions of the vascular endothelial cells are compromised, and then giving rise to leakage channels for fluids to flow through from the intravascular compartment to the interstitium alongside white blood cells, margination and eventual exit of white blood cells. Now, all of these put together would give rise to widespread microvascular thrombosis and capillary worsening capillary porosity. So, of course, your guess is as good as mine if I ask you what this will further lead to. So, there is further compromise in so there is you know, further compromise in vascular supply to end organs, alright? To end organs, for example, the kidneys. Okay, so further compromise in vascular supply to end organs in the kidneys. Alright, so this marks the beginning of the occurrence of multiple organ dysfunction syndrome, when this begins to happen in the capillary supply to all these, to the blood supply to all these end organs, and they give rise to these, they interfere with the function of these organs, expose these organs to ischemia, and eventually worsening other events down the spectrum of ischemia, even down to necrosis. Alright, and this will give rise to end organ damage, eventual end organ damage, and of course, multiple organ dysfunction syndrome. Let's go back again to charts over here. Where is it? Good. Yeah, remember we're looking, we're taking a closer look at the specific functions of interleukin 1 and 2 factor alpha in the occurrence of SIRS. Now, we've highlighted the propagation of the cytokine pathway, where they dissociate um, nuclear factor kappa B from its inhibitor, further activating other pro-inflammatory cytokines like interleukin 6, interleukin 8, interferon gamma. Further, we looked at the alteration of coagulation pathway, where they give rise to microvascular coagulopathy, which will further lead to end organ damage and eventual multiple organ dysfunction syndrome. Now, the third pathway through which this happens is that, okay, just over here. Yeah, the third pathway through which this happens is through the release of very important stress hormones. Okay, so stress hormones are released. Now let's look for a clear spot to further explore this. Yeah, stress hormones. Okay, it's through the release of stress hormones. Okay, now in the event of SIRS, there is a very high expression of catecholamines. Catecholamines, all right. Also, vasopressin is also released, and the remain angiotensin aldosterone system. What all these do is that they increase the expression of endogenous steroids. They increase the expression of endogenous steroids. And remember, let's go back to the remember when we were talking about the criteria to look at when making a diagnosis of SIRS, the defining criteria for SIRS. One, we talked about increased heart rate, we talked about temperature dysregulation, where temperature should be greater than 38 degrees Celsius or less than 32 degrees Celsius. And we also talked about increased respiratory rate. Now, catecholamines and of course white cell counts is crucial, right? So now catecholamines here, all right, will give rise to increased heart rate. Will also give rise to increased respiratory rate. Now these two here, all right. And of course, this is why we see these two in SIRS. Corticoids, okay. On the other hand, yeah, glucocorticoids will give glucocorticoids, okay, which itself is a steroid, glucocorticoids. Now, this will give rise to leukocytosis. Also, the margination, we've been talking about, we've been mentioning margination. Okay, imagination, where the white cells will begin to tend towards the vascular wall, and eventually they would escape through the endothelial leakage channels, right? So we've now seen how those criteria were highlighted in SIRS, or some of those criteria were highlighted in SIRS are talking about, right? Catecholamines giving increasing heart rate, respiratory rate, and with eventual increase in respiratory rate, there is a compensatory respiratory alkalosis, which is trying to correct the metabolic acidosis that that has been triggered by background and by the whole cascade of cells, especially when it's caused by an infectious cause. Also, vasopressin and renin-angiotensin aldosterone system all released, and of course, the increased elaboration of steroids, as we mentioned here in this instance, and glucocorticoids will give rise to leukocytosis and margination. Now, this is what happens at the cellular level in the pathophysiological mechanisms of SIRS. Now, what we've achieved in this video is that we have discussed SIRS, and remember that we mentioned that there is a SIRS. SIRS is just the beginning of the spectrum. Remember that what we're really looking at here is the sepsis spectrum, and we highlighted that this spectrum begins from SIRS, and from SIRS we move on to sepsis, and then to severe sepsis, to septic shock, and eventually multiple organ dysfunction syndrome. All right, and we have started this series of discussion by taking a closer look at SIRS, systemic inflammatory response syndrome. We've looked at the mechanism and the role of the stages. We've looked at the stages, and we also looked at the roles of the specific cytokines that are released in SIRS Especially, we've considered how interleukin 1 and 2 monocrosis factor alpha, which are the early cytokines released within the first hour of exposure to the insult, and then we looked at the three possible pathways through which they execute their function. One of such pathways is the propagation of cytokine pathway, and again they also alter coagulation at the level of the microvascular structures, and then also the release of stress hormones. In the next video, we will now have a full discussion on sepsis. Thank you very much for joining. Please subscribe to this channel and like this channel. Tell others about what we are doing here as we continue to bring out educating and engaging content to yeah, as we continue to bring out educating and engaging content. Thank you very much. Until next time, have a nice day.